was tasked to talk about the, optimizing CDK4/6 inhibitor in the adjuvant setting of early stage hormone receptor positive breast cancer. So I want to start the talk with recognizing the risk of these patients, right? So sometimes when we talk about hormone receptor positive breast cancer, we often think about, this long history risk of late recurrence, but we should not forget about that risk of early recurrence too. So this particular figure, kind of show that really well. So you can see that patient with early stage disease, even with, particularly stage 2 and stage 3, you can see that these patients still has high risk of early recurrence within the first few years. This is the study that was presented by Dr. Hope Bruco that also illustrated that well that I want to show. So as you can see here, this is basically the patient with high-risk node-positive disease, kind of similar to the inclusion criteria from the Monarch E trial. So this patient has either N2 or N3 disease, or if they're N1, they have to have larger tumor or high grade, like grade 3. So you can see that with the follow-up data up to 5 years, it's very sad that these patients actually perform as poorly, or if anything, might be a little even worse than patients with triple negative breast cancer that we know that they have high risk of recurrence. With the, up to 29.1% of patients develop recurrence within the first 5 years, actually surpassing patients with triple negative breast cancer. So we now know that we have, these CDK4/6 inhibitor in our armamentarium of a treatment of breast cancer. We have 3 CDK4/6 inhibitor that we have been used. It's actually been 11 years now since the first approval of palbociclib back in 2015. So you can see that with all these 3 CDK4/6 inhibitor, we now know that it may not created equally, and definitely they have distinct side effects among them. And we know that it works really well in patients with metastatic disease, and now we have the data coming out that it also perhaps it definitely helps with patients with early stage, particularly stage 2 and 3. So the first trial that I want to talk about is the PALAS trial. So this is the trial that looking at adjuvant palbociclib in patients with hormone receptor positive stage 2 and 3 within 6 months after starting on adjuvant endocrine therapy. And then they use adjuvant palbociclib for a total of 2 years. So the trial randomized patients to receive palbociclib for 2 years in combination with endocrine therapy versus endocrine therapy alone. So you can see that the trial unfortunately did not show significant improvement or any improvement with an addition of palbociclib. The other trial that I want to discuss is the Penelope B trial. So Penelope B trial, so this particular trial was conducted by the German group, and it's also a phase 3. But instead of focusing on the all-comer, they're focusing on high-risk patients that had residual disease after neoadjuvant chemotherapy that did not get PCR. And then they used that CPS-EG score, kind of similar to what the Olympia trial has used to select patients. And then among those patients, then they randomized to palbociclib versus placebo, but in this trial they only used palbociclib for 1 year rather than 2 years like in the PALAS trial. So you can see that in the graph, initially the graph did separate a little bit, especially during the first 12 months or so, but then unfortunately the curve came back and crisscross each other, and basically it did not show significant improvement at the end. So now let's switch gear to another CDK4/6 inhibitor, which is the abemaciclib, so in the Monarch E trial. So this particular trial, again, is a randomized phase 3 trial that enroll patients with high-risk node-positive disease, and that differ as patients with N2 disease, so more than 4 lymph node involvement, or if they have between 1 to 3 lymph node, they have to have either grade 3 disease or a tumor size more than 5 centimeters. They also has another smaller cohort, which is the cohort 2 that enroll patients with N1 disease but has high Ki-67. So basically they did not have grade 3 or more than 5 centimeter tumor, not meeting the cohort 1 criteria, but then they have high Ki-67. And then they randomized patients to receive abemaciclib for 2 years in combination with endocrine therapy versus endocrine therapy alone. And the primary endpoint of the trial is invasive disease-free survival, and then the overall survival is the secondary endpoint. endpoint. So as you can see here with the recent update from Dr. Johnston that presented at ESMO last year, you can see that with the longer follow-up, unlike the Penelope B trial, the curve continues to separate even after stopping the abemaciclib. And you can see that the delta now is about 6.5% absolute benefit with the hazard ratio of 0.73 that correspond to about 26% risk reduction with an addition of abemaciclib. So you can see that in the subgroup analysis across the board, like in the forest plots, you can see that across the board of patients seem to benefit from an addition of abemaciclib, even in stage 2 versus stage 3, and you can see in patients with grade 2 versus grade 3 tumor. This is the part that Dr. Johnston presented as an update at ESMO. So as the question that you got earlier that asked about the overall survival, now we actually do have the data on overall survival from the MONARCH-E trial. So you can see that with the longer follow-up, now with the median follow-up of 6.3 years, now there's actually a significant improvement in overall survival with an addition of abemaciclib in the MONARCH-E trial with about 15.8% risk reduction, and that corresponds to about 0.84 hazard ratio. So it does show significant improvement in overall survival now. And you can see that in the subgroup analysis for overall survival, again, across the board of patients seems to benefit with abemaciclib. Another thing that I wanted to point out from the analysis from the MONARCH-E trial is that the benefit seems to be across a board, like different age group. So you can see that on the left-hand panel, these are women, like younger women, less than 40 years old. So you can see that the the hazard ratio and the absolute benefit is quite remarkable with the absolute benefit of 10.3%. And then you can see that in the older population, more than 40 years old, the absolute benefit is about 7.1%. So you can see that if anything, younger women may actually perhaps derive at least the same or more benefit from adjuvant abemaciclib. The other point that I think that I want to point out is that with the invasive disease-free survival that they seen in this MONARCH-E trial, the distant recurrence is actually the majority of recurrence that we see in that particular trial. So you can see that almost like 72% of patients that developed that had that invasive disease-free event, it's actually a recurrence with the distant recurrence. So with this, we probably will continue to see more benefit of the adjuvant abemaciclib later on, especially with the overall survival with the longer follow-up. With regards to the adverse event, and it's basically kind of similar to what we already known with the abemaciclib. So mainly like diarrhea and some neutropenia and leukopenia, but the discontinuation rate is about 18.5%. And despite you can see that there quite a bit of dose reduction, and up to 43% of patients had dose reduction. But despite all of that, we still see benefit of adjuvant abemaciclib as overall in the trial. The other thing that I want to point out is diarrhea. So I normally counseling to my ladies that even though abemaciclib is associated with the diarrhea, the risk of diarrhea is mainly in the first few months. So you can see that with the longer follow-up, grade 3 diarrhea actually disappear like after they, about month 4 or 5, like month 5 or so. So I normally counseling patients that try to continue on it, and once your body get used to it, then diarrhea seems to get better with time. So with that, then I want to mention about the TRADE trial that was presented at ASCO this year by Dr. Mayer. As we know that, with abemaciclib and the risk of diarrhea and, discontinuation rate can be quite high. Up to 10% of patients actually discontinue by the first 3 months after starting on the drug. And about 27% of patients had a dose reduction with the abemaciclib. So what they did in the TRADE trial was that they start patient on the lowest dose of abemaciclib. So in the question that you had before the talks was how they did it in the TRADE trial, right? So they did not start at the regular dose of 150 milligrams. So basically start at lowest dose, which is the 50 milligram twice daily, and then go up the dose every 2 weeks, as long as the patient does not develop more than grade 3 toxicity, or if they have grade 2, it has to not be persistent. So if they do not have significant side effects, then the dose of the abemaciclib get increased like every 2 weeks. So you can see here that they enroll a total of 89 patients in the trial. If you remember from the Monarch-E trial, in the first 3 months or so, up to 10% of patients already discontinued the treatment. So the trial did meet its primary endpoint, and you can see that the discontinuation rate was only 6.7% when you do gradual increase the dose of abemaciclib slowly, as long as the patient does not develop significant side effects. And in the trial, up to 70% of patients actually were able to escalate to the full dose of 150 milligram twice daily dose. So this might be an option for some patients, to help them to be able to tolerate the drugs better. And you can see that the side effects, particularly with the diarrhea, grade 3 diarrhea, is only about 3.3% of patients. That's compared to about 7.8% in the Monarch-E trial, which basically if you do this, like go up the dose slowly, the risk of grade 3 diarrhea is actually less than half. So something to think about and can be considered in some patients. And then the last trial in the CDK4/6 inhibitor is the NATALEE trial. So NATALEE is also a randomized phase 3 trial that looking at adding ribociclib to endocrine therapy in the adjuvant setting, but their high risk entry criteria is a little bit different than Monarch-E. This particular trial also had N0 patients, so they also include patients with node-negative disease that has high risk. So meaning that they have to be grade 3, or if they are grade 2, they have to have high Ki-67 or have Oncotype DX score more than 26, or high risk other genomic profile. And then this particular trial randomized patient to ribociclib for 3 years. So instead of 2 years, like in the Monarch-E trial, this trial used 3 years of treatment, and the primary endpoint is invasive disease-free survival. So you can see that in the initial publication in the New England Journal, the trial did meet its primary endpoint, and that showed about 25% risk reduction with an addition of ribociclib with the hazard ratio of 0.75, and you can see that with the subsequent publication, when you look at even among the node-negative subgroup of patients, the hazard ratio is kind of similar at 0.72. So benefits still seem to confer across the board in patients with node-positive and node-negative disease. And then before I end, I want to show you a couple of the studies with the immune checkpoint inhibitor in hormone receptor positive breast cancer. So there are 2 clinical trials that was presented at San Antonio back-to-back earlier that looking at pembrolizumab and nivolumab in patients with hormone receptor positive breast cancer. So you can see that this Keynote 756, this is a trial that looking at adding pembrolizumab to chemotherapy, kind of similar to Keynote 522, but there's no carboplatin because these are hormone receptor positive breast cancer. And then they basically enroll patients with high risk node positive disease, or if they're node negative, they have to be T3 and then have to have grade 3 tumor. So in this particular trial, what they showed was that the PCR rate was significantly higher with an addition of pembrolizumab. This particular trial has a dual primary endpoint, so PCR and event-free survival. So we probably will need to see the event-free survival data on before routinely consider using pembrolizumab. But what I want to point out in this particular trial is that among patients with ER low tumor, meaning that they are ER less than 10%. So we all know that these patients are, often behave like triple negative breast cancer, but unfortunately they were not included in the Keynote 522 trial. You can see that their PCR rate is actually quite high, 57.6%, quite comparable to Keynote 522 with the PCR rate of 64.8%. And then the last trial was that Checkmate 7FL trial, so kind of similar to the Keynote 756, but instead of pembrolizumab, they use nivolumab, also in high-risk ER-positive tumor. So similar thing that was observed with the nivolumab in that ER-low patient, like 1 to 10%. The PCR rate is actually quite high, and then they also see higher response in patients with PD-L1 positive disease.